Assalamu alaikum. Good evening, everybody. Thank you very much, Professor Abdullah Shab and the organizing committee for inviting me to a cardiology conference, which I become a regular. It's 15 minutes. My previous colleague said the cardiologists, diabetologists take details. Yeah, we are very slow. You are very fast cardiologists because you deal with arrhythmias and lots of, but I'll try to do it in 14 minutes. What I'm going to do basically is I will take you through the guidelines which touch diabetes, and I will concentrate mainly on the new recommendation and whether those new recommendation has any implication in our daily clinical practice. Okay, so here we go. You see in this slide, probably in every talk, but probably every speaker have a different message. So I just would like you to start at the middle of the chart by looking at the confirming the diagnosis. And you can see diabetes and cardiovascular disease, diabetes and heart failure, and diabetes and CKD. So if we go retrospectively and look at the time where we made the diagnosis, probably it's difficult to put a line where we have the diagnosis. And we used to talk about the type 2 and complication, whether they start together, whether they precede the diagnosis, whether they start at the pre-diabetes stage where we didn't used to treat. So if we go back and look at the top, we'll find cardiovascular disease at the top and type 2 diabetes. And if you go down the chart, at the end, you will end up with the combining two diagnoses. So whether we'll have those two diagnoses stick together and we have one ICD code for those diagnoses, and probably the diagnosis will start much earlier, time will tell, but I can tell you yes. And I will not talk about the CKD, just because of the time. And what I will try to do to touch on the left-hand side by talking about the patient presentation, evaluation, diagnosis, and treatment. And this is what will get affected by changing the guidelines, which I'll go through. Then when you go down after you're making the diagnosis, things will become much easier, because if you have the diagnosis, the management will become much easier. So I will touch on type 2 diabetes, as the talk is type 2 diabetes. Then I'll talk about the atherosclerotic disease changes in those with diabetes when it comes to the guidelines, and blood pressure, lipid, and heart failure. But I'll keep in mind those 4 items I have shown you, and mainly to look at the new recommendation and those different 4 items. So when it comes to type 2, till now there is no change when it comes to the diagnosis, just not only the November guidelines, but if that's changed, that will have a huge implication in our daily practice because of the number. If we lower the thresholds for diagnosing type 2 diabetes, now we are treating pre-diabetes, and that's add lots of weight when it comes to either budget or to our daily practice as implication. But the figures are still the same, which is used by the ES guidelines recently, either to type 2 diabetes or to pre-diabetes. I think what's adding is that now it's recommended that every patient, okay, with cardiovascular disease should be screened for diabetes. And I think our cardiology colleague, they do that even before that recommendation. Everybody got cardiovascular disease, even if they are younger, one of the blood tests they do, or the screening they do, they screen for diabetes. And when we do our daily ward round, I can't remember one day where I didn't visit the CCU for those who they presented with first heart attack and they got newly diagnosed with diabetes. Of course, when it comes to what blood tests should be used, A1C or fasting blood sugar or oral glucose tolerance test. The oral glucose tolerance test we don't do very often these days because those patients present quite late and very evident from A1C they have diabetes. So when it comes to the atherosclerotic disease, my colleagues been through the risk stratification, and that's really important. And what's really good addition is that now we have the diabetes and that risk score with the score 2. And you can see the 4 ranges. Stratifying the risk is simplifying lots of things in us in the clinic. Not only that, but to convince our patient why they have to be on that treatment by telling them in simple terms what the risk they might have if they don't have that treatment. The recommendation when it comes to patient now, when it comes to the cardiovascular risk assessment, is that they screen of those patients with the presence of the, not only those with the target organ disease, also to assess the medical history. So it's become like medical student. We have to go through the systemic review by asking about the symptoms, signs, and I think we have a simple way, which all of us doing, but the guidelines reinforce this and encourage us to do it. The new recommendation is that even in those, I'm talking about patients with type 2 diabetes the whole way through, so I don't have to repeat it. However, those patients, even without symptomatic atherosclerotic cardiovascular disease or severe target organ, they recommended to estimate the 10-year risk, cardiovascular risk for all those patients with diabetes, even if they don't have symptoms. The rest of the recommendation, more or less the same when it comes to the target. And I just want to spend 2 minutes on the target, and that's for cardiologists and for us diabetologists. Since 2007, 2005, when the guidelines came out to individualize the A1C according to the patient comorbidity, for those 2 trials who they came out with those who they have advanced disease and they have hypoglycemia, and now we became more flexible when it comes to the A1C. I think we took that in the wrong way. Individualizing, okay, we have to keep a good target, especially now, a good A1C target and safe. Safe, what does that mean? That they don't have hypoglycemia. Now, we have lots of medication who they can bring the A1C down without high risk of hypoglycemia. So that the target should be a tight control, and this is that's to prevent the long-term complication when it comes to the coronary artery disease. And this is the new recommendation came out at the ESC guidelines. So the tight control is the tight control which fit that individual. But I see patients, they say, well, 8.5, that's safe for them. Those patients who they are A1C, 8.5, if you look at their blood sugar, they are quite fluctuating, okay? So they have hypoglycemia, not necessarily if they have A1C, that's mean they are safer from hypoglycemia. So we have to take that with a pinch of salt and make sure that they are under tight control by preventing hypoglycemia, and the A1C would be lower, and the recommendation as per ADA 7 or below. Blood pressure, when it comes to the masked blood pressure, which what we say high normal blood pressure, I think those, they have to be monitored, bring them back to the office, and you can do the home monitoring. And then the same thing when it comes to the hypertension, where they have 140 or 90 and above, those they diagnose being confirmed, and they should be treated. So the blood pressure, again, measurement. And I think when it comes to the blood pressure, we're doing lots of audit in my center, and it's more than 98% of patients who they come to the clinic, it doesn't matter what purpose they come for, they have their blood pressure measured. The other important thing, the screening. Okay, when you talk about the screening, so I mentioned that that's the new recommendation on the, no much change when it comes to the antihypertensive treatment, but the target is 130 to 139. The new thing is that you might bring that down if the patient have higher risk of cerebrovascular disease, below 130 and not below 120, of course, and that's vary from one patient to another. When it comes to evaluation, 24 blood pressure monitoring is recommended for those who they might have night hypertension or masked hypertension. Lipid treatment, risk stratification the same, and the targets the same, but those who they are intolerant to statin, the PCSK9 inhibitors are recommended on top of the ezetimibe. So you can use that as a combination. And those who they are not achieving the target on the statin. The other new recommendation that's those patients who they are not tolerant to statin or they don't achieve the target, the high dose icosapent ethyl 2 milligram twice a day is recommended in combination with the statin. Heart failure, of course, we heard a lot about the trials when it comes to the heart failure and SGLT2. And those trials, just a summary of those trials, which talking about type 2 diabetes, only those who they have high risk or established cardiovascular disease ending up with heart failure and CKD. And you can see they benefit when it comes to absolute risk reduction. And that's in comparison to the end pace with the placebo. So that's been proven, and that's why the SGLT2 jumped to the top when it comes in treating patients with heart failure with either preserved ejection fraction or mid-range ejection fraction or reduced ejection fraction. Those are, I will jump those 2 slides because it's already been mentioned, but the screening we are doing on the blood test, we do more or less the same, but they adding the ECG, chest X-ray, transthoracic echo, and they said routine blood test, and I don't like routine because this is not routine. This is a blood test to look after the patient, and most of the guidelines mention that. And in SGLT2 by names, they were what we can use when it comes to the heart failure for those who they are between class 2 and class 4. Cardiologists, you know better than me when it comes to the hydralazine. It's recommended to switch glucose lowering treatment from agent without proven without proven. So if you have some patient on medication without proven cardiovascular benefit, so you can switch those patient.
Can we get the slide on?
Yeah, that's okay. I'm there. I'm on the last slide. By the way, it's only 10 minutes to start with Abdullah. دايما سارقني انت. Anyway, that's they put 10 minutes on the screen. Anyway, so I hope I showed you how you jump between the new guidelines and the implication on the 4 steps we do on daily basis when we evaluate them and make the right diagnosis and plan the treatment for those patients relating to the new recommendation. I just want to send one message at the end of my talk. Multifactorial approach is the key. So we have to take everything together. And talking about achieving the target, if you look at the A1C, blood pressure, lipid, and weight and smoking, and if you put them together, only 28% of our patients achieving the target, which is mentioned by the guidelines. That's the slide at the end. This slide, if you want to look at it, it's probably difficult to put demarcation between the stages of the risk stratification. But we have to keep that in mind. Diagnosis and risk stratification is quite important. With that, I would like to thank you very much.
Thank you very much.